Module 6, Mobility. So we're going to talk about the concepts of mobility, fitness, physical activity, and exercise. So first, we're going to start by defining these terms. Mobility is simply put our body movement. The way our body moves is our mobility. Then we have fitness. Fitness is the same as physical fitness, and by definition in your textbook, it is the ability to carry out activities of daily living with vigor and alertness, without undue fatigue, and with enough energy for leisure pursuits and to respond to emergencies. So what does that mean in layman's terms? Well, that means that fitness means we're able to do our ADLs without getting tired, and we still have enough energy to do things outside of our ADLs, and we can also respond to emergencies, so like our fight or flight response. Then we have physical activity. So physical activity is body movement produced by the contraction of skeletal muscle that increases energy expenditure above our baseline level. So our baseline is us just sitting. Okay, all of the energy, our baseline energy consumption, just sitting versus us moving around and doing something, contracting our skeletal muscles. That is our physical activity. Then we have exercise. So this is a subconcept of physical activity, and exercise is planned, structured, repetitive, and purposeful movement that is for improving or maintaining our physical fitness, our physical performance, or our health. Now we'll discuss the physiology of movement. So activity and exercise requires body movement. And remember, we call body movement mobility. Okay, so activity and exercise require mobility. Mobility depends on the successful interaction among the skeleton, the muscles, and the nervous system. Okay, so to have optimal mobility, we're going to need our bones, our muscles, and our brain to make this happen. So the skeletal system, and this is just a review of your anatomy and physiology, include bones, cartilage, ligaments, and tendons. Okay, that is our skeletal system. So the skeleton forms the framework of the body. It protects the internal organs, produces blood cells, stores mineral salts like calcium and fat. So just one thing to remember is that bones feel strong and tough. We often think of them as like these dense structures, but bones actually have, they're vascular, they have living tissue inside, and they're constantly in charge of building and remodeling, so they're really important. Okay, so then let's talk about our muscles. These attach to bones at 2 points, at the point of origin and at the point of insertion. That's all we're really going to talk about that. You can refer back to your anatomy for more info. But muscles work in pairs. Okay, so they work in pairs. For example, the biceps contract to flex the forearm. When the bicep contracts, the opposing muscle, the triceps, relaxes. Okay, so they're always working together. Now, the nervous system controls the movement of the musculoskeletal system. Motor nerves are either autonomic or somatic. Okay, the autonomic nervous system consists of the sympathetic and parasympathetic nervous systems, which innervate involuntary muscles like the heart and blood vessels. So it gets kind of complicated, but just remember that this is our central nervous system. The brain controls this portion. Then we have the somatic nervous system, which innervates the voluntary skeletal muscles. So when you make a conscious decision to bend your elbow, the thought originates in the motor area of your cerebral cortex. Okay, the upper motor efferent nerves communicate with the lower motor neurons that then conduct impulses to the muscles. And when the muscles receive that sufficient stimuli, it contracts those biceps and triceps, for example. Okay, so again, in order to have mobility, the skeleton, the muscles, and our motor nervous system, they all need to be involved and working optimally to have good mobility. Next is the principle of body mechanics. So involved in body mechanics is body alignment, balance, coordination, joint mobility. All of these things work together, and this is going to come into play when we teach our patients, we educate our patients, and also when we conduct safe patient handling, which is how we move patients. So next is body alignment, and again, this falls under body mechanics. So if you look at this picture here, you can see the curvature of our spine. Proper posture maintains the natural curves of the spine. So if you don't have good posture, if you're sitting in your chair slumped over for long periods of time, that is going to affect your body alignment. So when we have good posture, it allows movement to occur with less stress and fatigue. So if you don't have good posture, there's going to be more strain on your bones, more strain on your muscles, and it's going to cause you to become fatigued, more tired after time. Good posture contributes to normal functioning of the nervous system and improves feelings of well-being. So if you sit up straight, you stand up straight, how your spine is naturally supposed to fall, then it actually should make you feel better, and overall, it's a positive thing for your well-being. So there are many things that can contribute to posture problems, and it can be one thing, it can be a combination of things. This is a list of some of those things. So accidents, injuries, and falls can cause your body alignment to kind of be off whack. Careless sitting, standing, sleeping habits, foot problems or improper shoes kind of will force you to walk kind of funny, so that can affect your posture. Negative self-image, maybe you're not very secure, you're not very confident when you walk, so that can cause issues with your posture. Occupational stress, poor sleep support, if your workspace is not ergonomic, meaning that it doesn't support good posture. Visual difficulties, makes you lean and squint, weak muscles or muscle imbalance, skeletal misalignment and malformation, which we're going to talk about. So we want to avoid injury, and that is why body mechanics is so important. So you want to remember these things. Okay, so use proper alignment. You want to make sure you have a wide base of support, especially when bending. You don't want to bend and twist at the same time. You want to squat to lift, so you bend your knees. You don't just keep your knees straight and bend over. You want to keep objects close to your body when lifting. That will help those muscles to support your back. You want to raise the beds when you're working with a patient. So especially like when you're doing hygiene and when you know you're going to be next to the patient for long periods of time, raise the bed to working height, but you also want to consider their safety. So make sure that those side rails are up. You want to push when you can versus lift, and you want to get help when you need it. If you have a large patient or a patient that's very weak and you don't think that you'll be able to support them, don't try it first, just call and get help to avoid injury. So now we're going to talk about the balance component of body mechanics. So you want to keep in mind Earth's gravitational pull is always pulling us down to the floor. So we want a broad base of support, and that is how we're going to keep our balance. Okay, so for example, if you are standing with your feet close together and you're trying to pick something up or you're trying to move something, transferring, you're not going to have a good base, so that might knock you off balance. Next is coordination. So coordinating smooth movements requires coordination between our nervous system and our musculoskeletal system. So this is our brain and our muscles and our skeleton. Okay, so 3 parts of the brain, cerebral cortex, cerebellum, and basal ganglia, they all work together to have coordination. So our cerebral cortex is involved in initiating our voluntary movement. Our cerebellum coordinates movement itself, largely responsible for controlling proprioception, the awareness of posture and movement, and the position sense. So kind of our, where we land in space. Basal ganglia, which is deep in the brain, assist with coordination of movement. So all of these things have their job. So if you have any kind of injury in the brain that affects these areas, then you're going to have an issue with coordination. So for example, if you have a stroke and there's blood supply cut off to one of these areas, whether it's the cerebral cortex, the cerebellum, or the basal ganglia, then that might affect gait, which is ambulation, walking, and posture. So again, if you have an injury to the brain in any of these areas or all 3 of the areas, you're going to have major effects on coordination. Then we have joint mobility. So we have to have joints in order to move within our environment. If you think about it, if you didn't have our hip joint or a knee joint or at our ankles, even in our fingers, it's really going to affect the way you can move and perform your ADLs, your activities of daily living. Our joints allows us to sit, stand, bend, and walk. Okay, so it's really important that we take good care of our joints. Range of motion. So this is our ability to flex these joints to full capacity. And you can see in this picture, each joint kind of has a different mechanism. Active range of motion is when somebody moves these joints all by themselves. And passive range of motion is when we are moving the joint for them. So some terms to review: flexion, extension, hyperextension, lateral flexion, rotation, abduction, adduction, circumduction, external rotation, and internal rotation. So these are all the ways that these joints flex. And you can refer to Table 29.2, range of motion at the joints, for a better explanation of each of those movements. Now we're going to talk a little bit about types of exercises. So isometric is muscle contraction without motion. You can see in the picture that the muscles are contracted, but the patient or the person is not moving. This type of exercise requires no special equipment and there is little chance of injury. So patients who are immobile, bedbound, can use these type of isometric exercises to maintain or regain muscle strength. Next is isotonic exercises, and this is movement of the joint during muscle contraction. So a classic example of isotonic exercise is weight training with free weights, and you can see here in the picture an example of that. As the weight is moved throughout the range of motion, the muscle shortens and lengthens. Isokinetic exercises are performed with specialized apparatuses that provide variable resistance to movement. So these type of exercises combine the best features of both isometrics and weight training by providing that resistance at a constant speed while the muscle moves through the full range of motion. So there's all types of machines that can do this. Also, as you see in this slide, different apparatuses that are available. Next, we have aerobic exercise and anaerobic exercise. So aerobic exercise occurs when the amount of oxygen taken into the body meets or exceeds the amount of oxygen required to perform the activity. So aerobic exercise uses large muscle groups and can be maintained continuously and is rhythmic in nature. It increases the heart and respiratory rate, which then provides exercise for the cardiovascular system while simultaneously exercising the skeletal muscles. So examples of this would be jogging, brisk walking, and cycling. So those are the common forms of aerobic exercise. Then we have anaerobic exercise. So anaerobic exercise occurs when the amount of oxygen taken into the body does not meet the amount of oxygen required to perform the activity. Therefore, the muscles must obtain energy from metabolic pathways that do not use oxygen. So rapid, intense exercises, such as pictured here, like sprinting and lifting heavy objects, are examples of anaerobic exercise. There are many, many benefits of exercise. So this is something that we educate to our patients. So regular physical activity each week that is sustained for months and years can produce long-term health benefits, and there's lots of evidence that link regular exercise, regular physical activity, with lower risk for early death, heart disease, stroke, type 2 diabetes, hypertension, hyperlipidemia, metabolic syndrome, colon and breast cancers, and depression. Some specific examples of how exercise improves cardiovascular health. Exercise increases the pumping action of the heart. It increases circulation by increasing the number of capillaries. It increases venous return to the heart. It increases blood volume and hematocrit. It also increases HDL, which is high density protein, the good cholesterol levels, and it decreases the low density lipoproteins, which is the bad cholesterol. And it also has benefits in our respiratory system. It increases pulmonary circulation, it increases gas exchange at the alveolar capillary membrane, and overall aerobic capacity. So patients are able to get more oxygen in with each breath. It also helps to dilate bronchioles for ventilation. So all good in the respiratory area. In our musculoskeletal system, benefits of exercise: it increases skeletal development in children, it increases muscle mass, power and endurance, increases flexibility, it increases coordination, increases bone mass, it increases gait speed, stability, balance. So lots of different benefits to our musculoskeletal system. Our central nervous system, exercise increases nerve impulse transmission, increases reaction time. Our endocrine system, it increases sensitivity to insulin, increases temperature regulation, facilitates weight management. So exercise has a ton of benefits. So we need to advise our patients to avoid inactivity and to be as physically active as abilities allow. That's the key phrase there, as abilities allow. Not every patient is able to, jog around the block or even walk around the block. So whatever that patient has the ability to do relating to their level of exercise, then that's what they should do. And like with any activity, there are risks associated with exercise. So cardiac injury. So some people may have a fear of triggering cardiac events, and that may make people not exercise. However, physical activity is rarely life-threatening, and when compared to the health benefit versus the risk, exercise is still recommended. Musculoskeletal injury can also result from exercise. If a patient does high impact exercise, that may pose a risk for injury to bones, joints, and ligaments. But these injuries can be prevented by ensuring proper body alignment, as well as gradually increasing the activity level or varying the activities that they're doing. If they're weightlifting, just to make sure they use correct form and appropriate weights, that can reduce the risk of injury. There's also a risk of dehydration with exercise. Fluid and electrolyte loss will occur with prolonged exercise. When there's high ambient temperature, if the patient's on certain medications, or if they have underlying health problems. So keep in mind that water is usually the best choice during and after most exercise, just because some sports drinks can contain sugar, glucose, and electrolyte replacement. So they may be beneficial to some patients, but overall water is the best thing to drink for exercise. Then we have temperature regulation. So hyperthermia, which is elevated temperature, can accompany dehydration, and this usually occurs when you're in a hot climate. The body just becomes too hot. This can lead to heat exhaustion or heat stroke, and that could be potentially life-threatening. You can also have the opposite, hypothermia, when you're exercising, and that could be to the person not sweating or not wearing the proper clothing, and they're exercising in really, really, low temperatures, exposed to cold weather. So now let's talk about factors affecting mobility and activity. First up is developmental stage. So depending on how old you are, what developmental stage, kind of puts you in a category of what type of activity you're going to do. So when we're born, we are total care, right? We're babies. We have to have everything done for us. Versus when we start walking, we are more mobile, we start running. And then as we get older, we kind of choose what kind of activities we're going to do. Older adults are the least active age group, and they're more likely to participate in fitness activities rather than going outdoors and sporting. So it just depends on preference. Moving on to nutrition. So nutrition, we're talking about maybe eating more than body requirements, such as obesity, chronic disease. Obesity often leads to other health problems, which indirectly reduces activity and can contribute to further obesity. So, for example, if you're obese, movement becomes more difficult as your body size increases. Joint and back injuries and osteoarthritis are more prevalent in obesity, which then in turn reduces a person's ability to engage in physical activity for weight loss. So it's kind of a cycle. Chronic disease may be in negative nitrogen balance, which we'll talk about later, which basically means they don't have adequate protein stores available to maintain and repair their body tissue. Muscle wasting and fatigue can occur, which can lead to reduced activity levels. loss of strength and balance. Next is lifestyle. So personal values and beliefs about exercise and fitness determine when or whether or not a person even exercises, or if it becomes part of a person's routine. Some people like exercise, some see it as, punishment or something they never want to do. So a person's personal preferences and support system will define what a person is likely to engage in. Environmental factors also affect mobility and activity. So whether if it's cold outside or wet, or if it's too hot or too humid, some people will avoid strenuous activity outside, or they'll just stay indoors. Their neighborhood, maybe it's not safe to jog outside or go to the park, or maybe they don't have gyms nearby to exercise. Pollution, if the air quality is poor, people shouldn't really be exercising outside. They can do indoor activities so that they have a reduced exposure to those pollutants. When it comes to finances, if they do want to join, they may not have money to do that. But many activities like just walking or like going to a park to play are inexpensive or even free, so that's what we want to suggest. And then when it comes to support system, family and friends who are active or likely to encourage, a patient to be active. So we want to definitely involve whoever the patient lives with, their social circle, so that we can encourage the patient to exercise if that's one of the issues. So this slide goes over musculoskeletal system disorders. So diseases and abnormalities in any body system can negatively influence body alignment, balance, coordination, and joint mobility. So for example, congenital anomalies, so things that we're born with, can cause issues with our musculoskeletal system. One example would be scoliosis. So that is a deformity of the spine that will definitely affect possibly our gait, our balance, our mobility. Any disease related to bone formation or metabolism, and that makes sense because we need a good, healthy skeleton to move and be mobile. Any diseases affecting our joint mobility, because we need our joints to move and do our ADLs. Any problems affecting our bone integrity, so the actual bone itself. So if you have anything wrong with your bones itself, that's going to lead to getting fractures easily, breaking bones, bone pain, any kind of trauma that you have on a bone. So if you injure a bone, it may not heal correctly. It may always have compromised integrity. And disorders of our central nervous system. So remember, our brain needs to process these things. So if you have an issue, an injury in the CNS, so if you had a stroke or some kind of spinal cord injury, that's going to affect our ability to be mobile. And then our other body systems, which we'll talk about, any kind of respiratory or circulatory disorder, fatigue, bed rest, is going to affect our mobility. Talking a little bit about trauma. So trauma can affect anything in our body, our bones, ligaments, muscles, and joints. So that is why it's important that we're aware of this. So fracture. So fracture is a break in the bone. And if a patient has a fracture, it's going to be painful at that site. They're going to have loss of function. You might see a deformity in the bone and possibly a line of bruising along the fracture. And because this is part of inflammation, we're going to have edema in those tissues. So fracture can only be diagnosed with an x-ray. Okay, so you don't want to tell a patient they have a fracture unless they've had an x-ray. And then we have sprains and strains. So the difference between a sprain and a strain. A sprain is a stretch injury of a ligament that causes the ligament to tear. So if it's just a partial tear, then it's usually healed on bed rest, but a complete tear may require surgery. A strain is an injury to a muscle caused by excessive stress on the muscle. Okay, so there's no tear. But the signs and symptoms of both of these are very similar. They're going to have that edema, they're going to have loss of function, pain, redness. So it doesn't matter which three of these patient presents with, we're going to treat it the same with the RICE interventions. So we're going to have the patient rest, we're going to have them apply ice, elevate, and compression. So now let's talk about the effects of prolonged mobility. So our body is not meant to be in bed for long periods of time. We are meant to walk around and we're meant to use our muscles and our bones and our central nervous system. When we are immobile for long periods of time, things start to change in our body, and it's important that you recognize these changes because of a lot of our patients are immobile and they're sick and they're going to be in bed for a couple days or maybe for the rest of their lives. So it's important to understand the changes that are going on in the body. Now, these changes happen pretty quickly, and about after 3 days is when things start to happen. So even a young person who had some type of accident, they're very sick and they're in the hospital for 2 weeks, after about 3 days, some of these changes can start happening. So we have to make sure we assess for these things. Okay, so first off, musculoskeletal. So we can have muscle wasting, stiff joints, and contractures over time. Our cardiovascular system, decreased circulation, edema, venous stasis. So these patients are at risk for orthostatic hypotension, which we talk about in another slide. Respiratory is going to have decreased ventilation, which is going to cause shallow breathing. They're not going to be able to take a really big breath over time. When we lie flat, it causes secretions in our lungs to kind of pool, and that can harbor bacteria. They're going to be at risk for atelectasis and pneumonia. For our skin, being immobile puts a lot of pressure on our bony prominences that can lead to pressure injuries. Our metabolism is going to change. Patients will have decreased energy, decreased metabolic rate. They're going to develop glucose intolerance, decreased muscle mass. This stress response is going to trigger lots of hormones to be released. There's going to be secretion of calcium from the bones, which means that's going to affect the integrity of the bone, which is going to put the patient at risk for fractures. Our GI system slows, peristalsis is going to slow, which is the contraction of our intestines to get food or to get stool out, and everything that we eat is going to slow down, so that our appetite is going to diminish and patients are going to have a decreased calorie intake. And because of that, muscles are going to start to be broken down as a primary energy source. These patients can get constipated, so doing a good abdominal assessment, it should be part of your assessment every shift. So listening to bowel sounds, making sure the patient has a bowel movement regularly. Our urinary system, so being in that supine position on the back and horizontal, inhibits drainage of urine, because when we stand up, gravity is helping our bladder drain urine into our ureters. And because of all of this muscle wasting, those little muscles that help peristalsis in our ureters kind of go flaccid too. So if we don't have gravity to help drain our bladder, it's going to just stay in the bladder. So we're going to have urine retention. All of the calcium levels, if you remember from the bone, it's going to lead to stone formation. So these patients can have kidney stones. And also being in the horizontal position, if the patient is continent and you give them, bedpan to use, if they're on bed rest, just having a bedpan having to urinate in the horizontal position can lead to urine retention, not emptying the bladder. Psychological. So being in bed for a few days does have an effect on your psyche. You get depressed, you feel withdrawn, you can become irritable. So all of these things we need to be aware of with our patients who have prolonged mobility. So when we treat patients, and as you move on further into your Med-Surg classes, the way you want to think of disease processes and conditions is by always being aware of what the complications are, because that's what we're trying to avoid with our patients. If they're sick, okay, we're treating them for whatever illness or condition they have, but we don't want it to progress. We don't want it to get worse. So we're always thinking of complications. So our condition we're talking about right now is prolonged immobility. So these are all the complications that you need to keep in your mind. Pressure injury. So what kind of interventions are we going to do for that? Turning. We're going to assess the skin to make sure we don't see any impaired skin integrity, any redness, any moisture, keeping the patient clean and dry, turning the patient every 2 hours. using the facility, whatever facility products they have, the barrier creams. We want to make sure we're using any kind of external urinary collection devices to keep that incontinent patient clean and dry. Changing the linen. Those are all interventions to reduce pressure injuries. Constipation. So we know that's another complication of prolonged immobility. So we want to make sure the patient is hydrated. We want to make sure their nutrition has adequate fiber. You want to bring a registered dietitian to make sure that they're assessing these patients also. Also, repositioning the patient helps with constipation. So you'll see in the hospital a lot of times, older patients, when they come in, the doctor automatically orders a stool softener for them. Well, maybe that's not always appropriate for the patient, and that's not good practice to just give out medication just because they're being admitted. You really want to look to see how much your patient is eating, what they're drinking, what their status is, and do all the non-pharmacological measures we can do to prevent constipation. Next is joint contracture. That's where that range of motion comes in. If the patient's able to move their joints, then we want them to do exercises in bed, to raise their arm, to bend those joints, to do, circle motions with their ankles, to bend their knees. If they're not able to, then we can help them. We can provide passive range of motion on those joints to avoid contracture and joint stiffness. Then we have muscle weakness. All of these things are tied together because immobility affects the body from head to toe. So again, having those strengthening exercises depending on the patient's level of mobility. Balance problems. Again, this is tied to that muscle weakness and those joint stiffness. So it's all about getting the proper nutrition in to give the body the nutrients it needs to build up those muscles and to offer exercises that the patient can do while they're in bed, so that when they sit up and they stand up, they can build that core. DVT, this is blood clots, and this is related to impaired circulation in the body. So what can we do to prevent this? Turning patients, range of motion, again, those exercises, using those anti-embolic stockings, those sequential compression devices that squeeze the legs to increase circulation, adequate hydration so that their vessels are free flowing. Next is pooling of secretions in the lower lobes of the lungs. So we want to do a good respiratory assessment. We want to listen to their lungs. We want to check their oxygen saturation, count their respirations, check to see if they are shallow breathing. We want to sit them up, facilitate them taking deep breaths, coughing, repositioning. Okay, all of those things will help with getting those secretions out of their lungs. Orthostatic hypotension, the next slide we're going to talk about that. And prolonged immobility increases the risk of mortality, meaning that if a patient is in bed for a long time, it's going to make them die faster. Research has shown, if we can get them out of bed, walking around, back to their baseline sooner, then they have a less risk of dying. Okay, so now let's talk about orthostatic hypotension, also referred to as postural hypotension. So prolonged immobility inactivates the baroreceptors involved in vasoconstriction and dilation. So baroreceptors are in our bodies, and they're these receptors in our in and around our blood vessels. So usually when we're walking around, we sit, we stand, we lay down, our body knows what's going on and it adjusts appropriately. It's constantly constricting our blood vessels, dilating our blood vessels so that circulation still remains intact and fluid at all times. But when you are in the horizontal position, prolonged immobility, you're not moving, those little receptors don't work as well and they kind of go to sleep. They're not as reactive as they should be. So they're less able to regulate blood pressure. So when you have a patient in bed and you sit them up after they've been immobile for a while, the blood pressure is going to drop significantly because the body just can't regulate the constricting of those blood vessels, and they can become dizzy and lightheaded. They can fall, definitely high fall risk. So how do you measure an orthostatic blood pressure? You're going to measure the blood pressure when the patient is lying down, and then you're going to sit them up and then you're going to stand them up and you're going to measure the blood pressure each time. You can see here you have the patient lie down for 5 minutes, and so on. If there is a difference of 20 millimeters of mercury of the diastolic BP, then or 10, and they're symptomatic lightheadedness or dizziness, that is considered abnormal. So even if they stand up and they're dizzy and they have symptoms, but when you take the orthostatic blood pressure and it doesn't meet the criteria, we still consider them having orthostatic hypotension. And if they have no symptoms but their blood pressure still drops, then they still have orthostatic hypotension. So with these patients, we're going to dangle them. You're going to ask them to get up slowly, sit at the edge of the bed for at least 2 minutes so that their body can kind of realize, hey, you're sitting up, and it can, create homeostasis again. These patients, you want to make sure, because they're a high fall risk, that they don't get out of bed unless they call for help. Now, if the patient is confused or a little forgetful or non-compliant, because maybe it's a 30-year-old who has this orthostatic hypotension, then you may want to put on the bed alarm so that you know when they're trying to get out of bed without help, because these patients will fall. So we want to promote venous return, because this can also help with that hypotension when they sit up. So anti-embolic stockings, okay, we do need a doctor's order for these. These are also referred to as TED hose, and they come in different sizes. Sometimes the toes are enclosed, sometimes the toes are open, sometimes it's just up to the calf, sometimes it's all the way up the thigh. So these apply pressure on the vessels in the legs, and it kind of helps that venous return, that blood to return back to the heart. In the second picture here, we have sequential compression device, SCDs. Those are a machine, they're plugged in, they sit at the foot of the bed, and there's a little tube that hooks up to these sleeves that are wrapped around the patient's calves. And they alternate left to right leg, they inflate, they deflate. It's kind of like a massage on the legs. These also need a doctor's order. These are contraindicated with patients who have a DVT, a known blood clot. You should not be putting these on the legs because it's kind of like a massage, and we do not massage legs that have a DVT in them, because in the massage you might dislodge that little blood clot, and then it's going to be free to travel, around the body and hopefully not up into the lung, which is what we're trying to avoid. Other ways to promote venous return would be to reposition the patient, to do range of motion exercises. Patients who are immobile, and if they're still able to do leg exercises, they should do that, increase fluid intake, and change positions frequently. This is just a recap of different interventions that you can do as the nurse for patients who are immobile. We talked about supporting oxygenation. So if you can sit the patient up so that they can better expand their lungs, this will help to prevent atelectasis and pneumonia. These patients also need protein-rich diets to maintain that muscle mass, and often high-calorie diets also. Support skin integrity, of course, turning that patient every 2 hours, keeping them clean and dry. You don't want to tuck them in really tight to restrict movement, especially that foot drop that we talked about. Support cardiovascular function, so that would be dangling to prevent hypostatic hypotension. And overall musculoskeletal system support, having them exercise to help before they get out of bed to walk. Definitely want to avoid injury and fall, so make sure that you're there when they get out of bed, and assist with ambulation as tolerated using a gait belt. So when you're doing assessment related to activity and exercise, you want to check their vital signs, get their height and weight so you can determine their BMI, check for body alignment, joint function, actual gait, muscle strength, and activity tolerance. All of these things are involved in when you're assessing their activity and exercise. So when a patient has very limited activity and you're assessing them, we're going to assess 2 categories: ADLs, which you're familiar with, and then instrumental ADLs. So instrumental ADLs focus on things that are instrumental in helping a patient maintain an independent living status. So things like doing their laundry, cooking in the kitchen, actually leaving their home to go buy groceries, and just maintaining their household. So if you have a patient that's not able to do those things, you need to recognize that and get a case manager involved, maybe a social worker, because these patients may not be able to return back home after leaving the hospital. So we want to really promote activity, and just to keep in mind that healthy people are able to, regularly shift their position to maintain comfort. So as you're sitting in class, sitting in a chair, and your brain says, hey, we've been sitting in this position too long, I'm starting to feel some discomfort, you're able to shift your weight over and then you feel better. Well, patients who are unable to move without assistance, if they get that message, maybe they're not able to move, and maybe they don't get the message because of some type of condition, and they don't move. So that is going to lead to problems. So these patients definitely require position change at least every 2 hours to prevent that skin breakdown, that muscle discomfort, the damage to superficial nerves and blood vessels, and to prevent contracture. So really important. So we want to make sure you as a nurse, you have proper alignment of the hospital bed when you are dealing with this, meaning raising the bed. And if you see in this picture here, you want to protect your back. We want to use range of motion on these patients. We want to prevent all of these injuries. We want to use what we have, so pillows, wedges, side rails, trapeze bar, splints. All of those things are available to us, so we want to use them. When we position our patients, we want to protect our back. Okay, so you want to make sure you get help when you need it. We want to avoid manual lifting when possible. So if you have a Hoyer lift or any kind of assistive device, you want to use it. It may take a little extra time on your part, but it is worth having that extra safety. You want to make sure the room is free of clutter. You want to, of course, if they're at home, make sure you watch out for uneven floor surfaces and movable rugs. You want to educate your patient on that. And of course, wear supportive shoes, non-slip soles. There are different beds available. There's the standard bed, there's adjustable beds, specialized beds. These are all aimed to help the patients who are immobile, who can't move, and reduce the pressure injury risk, trying to help you out as a nurse. Pillows, lots of different pillows, utilize them. If you don't have pillows, you can fold a blanket or even roll a towel to help reposition patients. Use side rails. Patients can kind of grab a hold to the side rail and help themselves move. And trapeze bar, as you see here in the lower left picture, patients who still have that upper body strength can help themselves reposition in bed. And here we have the different positioning. So we have semi-Fowlers, standard Fowlers, low Fowlers, and high Fowlers. So for this, semi-Fowlers is just 45 degrees or so, and high Fowlers is 90 degrees. We typically don't say standard Fowlers. Sometimes we say low Fowlers. Just know that Fowlers is not flat, okay? You're elevated. Then we have prone, which is face down, supine, which is on your back. We have Trendelenburg, where the feet are raised, and reverse Trendelenburg, where the head is raised. Orthipneic, you see here sitting up, kind of hunched over with some pillows. We have Sims, and we have lateral. So just some terms that you should remember. Then we have to know about moving patients in bed, moving up, turning, log rolling, and then using some friction reducing devices. So when you're moving patients up in bed, so frail patients tend to slide down in bed because of gravity, and they're just not able to correct their position. So when you elevate the head of the bed, it kind of makes them go down like a slide. So if you lift the knees up, that might help them kind of stay in place. Turning in bed, we know that's one of the most important interventions to help prevent pressure injuries and other complications from immobility. So it's easier to turn a patient to their side when they're a little bit flatter. If it's not contraindicated, definitely lay the patient flat before turning the patient side to side. And of course, use pillows and other positioning devices to help reposition that patient. Log rolling is a technique used when the spine must be kept straight in alignment. So you want to get at least 3 people to help you turn these type of patients. One is going to support the neck, one will support the top part of the spine, and then the bottom legs, as you see in that picture. Then we have friction reducing devices. So you can see that in the picture on the left. It's kind of like a slippery sheet that you can use to slide patients up and down, reducing friction and shear. Transferring patients out of a bed, you have to be really careful because if you are with the patient, there's high potential for them to fall. So there are transfer boards, and you can see in the picture how these transfer boards are used. Patients can use this independently. They're usually taught by the physical therapist how to use these. So the idea behind this is it promotes a smooth transfer. You place the board under the patient on the side they're going to be moved, and then if the patient can't help too much, you can actually put a sheet under them and slide them with the sheet. But then also patients who have maybe weakness in their lower extremities, but they're still able and they still have upper strength, they can kind of slide themselves over. Then we have mechanical lifts. So these are nice because if the patient's obese, very high weight, this keeps the patient safe, moves them around, up in bed. You can put them in the chair or on another bed. When you help the patient out of bed, you want to use a gait belt when appropriate, and this just gives you something to hold on to so the patient just doesn't fall down if they're weak. So physical conditioning, if you know a patient's going to be getting out of bed, you want to help with isometric exercises. That's something that they can do in bed. Arm exercises, we want to have them dangle to prevent orthostatic hypotension. Again, if we have those stockings on them. Abdominal binders are like a binder with Velcro around the abdomen. And then if it is a true problem that doesn't resolve after dangling or the other interventions, then they may need medication to help control that orthostatic hypotension. We want to make sure that the patient is ready to get out of bed. So we want to assess their readiness to walk. Are they going to have the strength? Are they alert enough? Are they able to follow, instructions? You want to make sure you get the appropriate equipment. Maybe you need the sliding board or the gait belt or maybe an assistive device like a cane, a walker. You want to move anything out of the way, and you want to use a transfer belt when possible, and have a chair on standby if it's like the very first time, or maybe have somebody follow you with the chair as you walk the patient. There are lots of devices that could be used. There are canes here in the picture. You can read about those more, it just depends on the level of assistance that the patient needs. Walkers, these are lightweight. Some are more fancier than others. This one on the right has a little seat that the patient can sit on if they get fatigued. Here is some mnemonics for you to remember which leg goes first with what device. There are braces that can be applied. It just depends on what condition the patient has. They may benefit from this. It kind of keeps supports the joints and muscles, and usually this is done by an orthopedics doctor, or sometimes physical therapy can arrange for this. Your responsibility would just be to make sure it's applied correctly and that there's no skin breakdown under the device. We have crutches. So crutches are typically they're temporary. Maybe they had some type of injury, but with some conditions, maybe like cerebral palsy, they will have long, they'll use those indefinitely, like the ones on the left. So here's another mnemonic just to help you remember how to size those correctly and how to go up and down with crutches. Assisting a fall. So sometimes you'll take up a patient, you're walking with them with the gait belt in the hall, they're doing well, but then maybe all of a sudden they just can't walk any longer and they're falling. So don't attempt to hold them up. You want to look to see if there is a chair close by, and I mean within arm's distance. If there is not, you're just going to guide them down onto the floor, either sitting or lying position, as seen in the picture. Really important we try to prevent falls because they happen every day in facilities across the nation. They're the most common incident reported in hospitals and long-term care facilities, and falls occur more frequently on the nights, weekends, and holidays. This is ongoing for years and years, very common, and they're trying to prevent this in all facilities. One way we can do this is with standardized tools. So if we identify the patients that are high risk, then we can hopefully kind of pay more attention to them. That's the idea. So here you have the Morse fall scale. If you click on that link, it'll take you to the full version where you can read about it. But basically, you're giving them a score based on these things. If they already have a history of falling, that already puts them at risk. If they have any type of secondary diagnosis, same thing. If they are using any type of assisted devices, here where it says furniture, that means they don't have an assisted device, but they kind of hold on to things as they walk, like the wall or the bed rail. If they even have an IV heparin lock, what that means is even if they don't have any tube connected to their IV, if they just have an access point, that already puts them at higher risk for falling. If they are weak or impaired, of course, that's going to put them at higher risk. If they have altered mental status, if they forget their own limitations, then that puts them at a higher risk. So this type of tool is used every shift if you're working in the hospital, because we know things can change of condition. The surgery is an example. Maybe when the patient was admitted to the hospital, they were low risk for fall, but they had their surgery, they came back, now they're high risk for fall. Lots of risk factors for falls. If they're over than 80, if they already have gait problems or balance problems, if they're in pain, that can affect their fall risk. Of course, orthostatic hypotension, if they're on lots of medications, if they're in an unfamiliar environment like the hospital. So any patient, this is an unfamiliar environment, so that could just put them at risk. Falls can lead to death. They can get hurt, they can break a bone, it can cause loss of independence. For example, if you have a patient who's 80 years old, lives alone in their house, completely independent, ADLs, cooking, showering, everything, and then they slip and fall, they break their hip. All of a sudden, now they're immobile, they're in bed, and maybe they won't be able to recover, maybe they're going to be bedbound. So falls can really be detrimental and can lead to death. So fall precautions, what can you do? You want to review medications that the patient's on. You want to round frequently on your patients to make sure that they have what they need so they don't try to jump out of bed or, crawl out of bed without calling for help. You want to orient the patient, say, hey, your call light is here. Here's the remote for the TV, here's your phone. You want to place disoriented patients closer to the nurse's station so you can kind of keep an eye on them. You want to make sure that they have all of the things that they need frequently next to them. If they need a night light so that they can see the room when they get up, that would help reduce falls. Keeping the floors dry and free of clutter. Educating patients and their families, of the fall risk and what to do when they need help. Identify those who are at risk, especially those who are at high risk, and use chair and bed alarms when necessary. And our final slide. This would be a fall bundle. So in hospitals, they come in a kit, and it's usually yellow. You have yellow socks, yellow wristband, and a little yellow throw blanket. And then you have a magnet to put on the outside of the door on these patients who are at risk for fall. So make sure every shift when you're the nurse that you do all these things, because if the patient falls, you're going to have to document that you did do all of these things. You did round on the patient, they had their socks on, they had their call light within reach, and the patient still fell. All right, so that concludes this module.